The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery. and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good afternoon, everyone, and thank you for joining us for PerfWeb Corona 30, Part 2, Day 2. So welcome to the program. I want to thank our sponsors, LivaNova and Siemens. We need more, so if you're a sponsor, call us, please. Social media, please like us, follow us, share us on the Facebook, the Tweeteroo, and the LinkedIn, and subscribe to our YouTube channel. We need 1 million new subscribers before the end of the show, so subscribe, please, and click the thumbs up button. Also hit that notification bell icon so you get notified when we go live, please. Check out our websites, perfusioneducation.com. If you would like to join our faculty or you have an idea on a topic that you would like, or a case report that you would like to present on our show, the emails, I will answer them personally and discuss it with you. Would love to get you on our resident faculty list. We have some incredibly talented people that are on that, and you're going to see more of them, of course, starting next month. This Corona 30, you know, I did for the coronavirus, which I'll talk a little bit about here in just a second. Our call-in number, email us, contact at perfusioneducation.com. There's our call-in number. If you want to call, be live on the show, feel free to call that number. We'll answer it right over there, and you can be live on the air. So our topic today is minimally invasive hemodynamic monitoring and goal-directed therapy. Oh, did I forget something? I forgot the Slido. Yeah, the Slido. Make sure you go to this website, type in PerfWeb C30-8, or use that QR code, whichever you prefer, and vote on the poll. You know, do you scavenge your exhaust gas, your anesthetic vapor from your exhaust gas on your oxygen or bypass? We need that for Patrick's show tomorrow, which is going to be a great show. Patrick is going to be here. He's going to discuss this topic. It's going to be a really good program tomorrow. Okay, so my topic, minimally invasive hemodynamic monitoring and goal-directed therapy. Before I get into the actual presentation, I got to tell you, you know, and when I first did this, you know, with the Corona 30, wanting to help out because I knew meetings were going to be canceled and people need their points and all that kind of stuff. And it's been very successful. It's been a really highly successful program. I'm really glad that we did it. But everybody, everywhere I turn, is trying to out-Corona each other. Every advertisement on TV is about together apart and all of this stuff. I don't know where y'all are, you know, in terms of how you feel about all of this. every patient is COVID. It doesn't matter. They come in with an amputated foot and they're COVID. The COVID knocked their foot off, not the knife or the hacksaw or whatever else it was, or the accident. Everything is COVID. And frankly, I'm getting sick of it. I think it's a big problem. I think we need to address it. I think we are addressing it. But I'm just really concerned about how we're handling it and what the impact of this is going to be on a whole bunch of patients who, for the past month, have essentially been pushed to the side and having to wait for services that they typically desperately need. And I'm going to be real interested to see if anybody's able to figure out the mortality rate associated from other causes, whether that's increased during this COVID-19 pandemic crisis or whether it did. My suspicion is it did. However, with that said, we'll still do a couple of probably COVID talks. I know we're going to have the first patient that was put on ECMO, the very first patient put on ECMO here in the greater Houston area. This includes downtown. So we were before the med center. The first patient did very well, is very eager and excited about coming here to the studio when it is appropriate. We're still exercising social distancing and all of that, but he wants to tell his story. It's a fascinating story. It's a great story. And he's a great guy, great, fantastic individual. I'm so glad he did well with a very loving family. So we're going to be doing a little bit of that and also some other updates on Corona and COVID-19. But I really just don't want to make this whole next year about COVID and COVID-19. There's a lot of other things involved here, and everybody is doing nothing but that, and I don't want to just do that. So we're going to do some other stuff. We're going to try to make it fun. We're going to make it pithy. We're going to make it interesting. We're going to make it inclusive. We want a broad audience, which we have currently, but we want to continue to grow it. Right now, PerfWeb is, and I think this is a provable fact. I think PerfWeb, our live programs, and even our library has become the largest, by far, the largest perfusion education resource site, tool, whatever you want to call it, in the world. And we want to continue to grow. We want to continue to bring quality programming that's meaningful and that is out of the box thinking, not just the same old humdrum that you hear some other places, not everywhere. Some conferences are great. I really do want to go back to live conferences. I think live conferences are unique in the sense that something you can't do here. We try, but you're not sitting next to somebody and bumping elbows versus shaking hands now. And when that comes back, I want you to know I'm going to do another The New Orleans Conference in New Orleans, and it's going to be a great program. I'm going to make it the best we've ever done. But I also want to do some live programs here in Houston on some really good topics as well, because there's so much about medicine, so much that the future holds. And perfusion to survive, separate topic, but for perfusion to continue to not just survive, but thrive, we have to be on the cutting edge of both technology and information techniques, the procedures. We have to expand the services that we provide. Of course, Darwin's theory was not really the strongest survival. It was the most adaptable. And for us to survive, we all know that, but for us to survive, we need to be adaptable. And that's what we have to do, adapt, overcome, and conquer. And that's what perfusion needs to do. That includes nurses, that includes mid-levels, nurse practitioners, PAs, that includes physicians. That's everybody in healthcare. We constantly have to be improving and evolving. Okay, I've talked enough, on with my talk. So I gave you the title already. I don't have any disclosures. And before I really get started, I really have to thank Victoria Crumpton, RN extraordinaire, and she helped me with these slides. She was unable to give the presentation. She was actually scheduled to give it, but she's unable to do that. So I'm giving it in her stead. So I want to compliment her on the work that she did, and I want to give her full credit for all of this. So Victoria Crumpton, if you're out there listening, thank you so very much. This, I think, cartoon illustrates where we're at. You know, we go into a patient's room and we see massive amounts of lines and tubes and measuring pressures and so forth all over the place. And is that really the best way to do all of this? But first, we need to understand what is goal-directed therapy. Goal-directed treatment protocol for volume optimization, which defines and treats to a goal using advanced hemodynamic parameters to maximize tissue oxygen delivery. That's really going to be the theme here, is oxygen delivery. The critically ill patient will generally, you'll see them with a DO2 or O2 deficit to the tissues for a variety of different reasons. But the key is to correct that deficit by optimizing their hemodynamic cardiovascular status. And there's ways to do that. There's old ways to do it, new ways to do it, some that are effective and some that are more effective. Okay, so we'll talk about those. So early goal-directed therapy parameters are CVP, mean arterial pressure, urine output of greater than 0.5 milliliters per kilogram per hour, and a mixed venous oxygen saturation of 65%, or an SC, a central venous oxygen saturation of 70%. Hematocrit of greater than 30%. And for those of us in the cardiac world, this perfusion, 30% sounds remarkable, because I mean we've had conversations and talks about tolerating hematocrits of 18% on patients who have had heart bypass surgery or even valve replacement, and doing it effectively. But in the critically ill patient, I don't necessarily agree with that. Once you start seeing problems, that kind of anemia is going to be a problem, because your oxygen carrying capacity is just too low, in my opinion. The interventions that we're used to doing are to reduce work of breathing by early use of mechanical ventilation. So the patient is, you know, tachypnic and they're running out of gas, so you put a tube in them, put them on the ventilator, right? Fluid resuscitation, use of vasoactive agents such as norepi and dobutamine, and transfusions. Those are our typical interventions. The principles of applying early goal-directed therapy for septic shock is based on the observations that, and I say septic shock because septic shock is a big, big problem. But I've also seen a lot of cardiac patients who, they may not be septic, but they look like they are in septic shock. And I think there's some real parallels there with patients who are in very severe cardiovascular dysfunction. But early treatment for myocardial infarction, acute ischemia, stroke, and trauma improves outcomes. So patients that come into the hospital with ACS, a STEMI, acute ischemic stroke, or trauma, those patients, if they're treated early, have improved outcomes. Kind of like what we hear about the golden hour on the battlefield. If they can get the soldier who's been severely injured, critically injured, to a field hospital, and within that hour, their chances of survival go up very significantly, okay? Patients presenting to the emergency department with a diagnosis of sepsis have a measurable O2 deficit. This is understood, right? For septic shock, the hypothesis is that early optimization of the compromised septic circulation may reduce mortality. That basically means improving DO2. At the end of the day, in my view, that's what this is all about. The arguments for early goal-directed therapy are that there are sensible endpoint for O2 delivery as SCVO2 reflects supply-demand balance. So you have your oxygen delivery, you have extraction, and you have a central venous pressure. And a lot of this work was done by Dr. Rivers, Manny Rivers. I think he was from Detroit. I don't know if he's still there or not. But before him was Shoemaker and several other people. So goal-directed therapy is not a new concept. This has been around for well over a decade, maybe even 2 decades, to be honest with you. But it's never really, it's just, I don't know why, but it's kind of embraced, but not embraced, I don't think, to the degree that it should be, all right? Our patients all have central venous lines, okay? In the ICU, but not necessarily in the emergency department. The Rivers trial, Dr. Rivers, showed a substantial reduction in mortality with the use of the central venous O2 saturation, which is measured, at the I think the SVC bulb monitoring versus standard care. No other O2 delivery endpoint has ever been validated but that. It's recommended in surviving sepsis guidelines. The SCVO2 is readily available with an IJ stick. It can have continuous monitoring, which it does. It responds quickly to therapy, quickly, not instantaneously, but quickly. And it is highly predictive of outcomes. Those are good reasons to use it, right? But there are arguments against it. Protocols for implementing EGDT usually result in more fluid being administered, more use of vasoactive medications, and more use of blood transfusions, which may lead to fluid overload. You can get abdominal compartment syndrome. We've seen that. The belly's real tight from all of the edema in the gut. Tissue edema impeding essentially oxygenation. It's a dysfunction of the microcirculation, which is something else that I'll bring up before I go to the next point, is how many times have we seen a patient where they are so swollen now that what used to be a loose strap on their arms or on their wrist to restrain them are now tight. You can see they don't look sometimes human anymore. The families come in and just are appalled. It's frightening to them to see this patient that swollen. Well, when you can see that, when you can look at a patient and see that kind of massive edema, you have to keep in mind that the organs that you cannot see, and I've seen it, I've seen patients that look like that where we've opened the sternum up and the surgeon's opened the chest and you look at the heart and you can see how edematous it is. In fact, I've seen it so edematous they couldn't approximate the sternum. And there's a way to treat that. And usually what you see is they've been giving massive amounts of fluid, boluses. The albumin is usually in the tank. The COP is way low. And you just get this massive third spacing. Well, again, you see it. It's not simply a visually displeasing finding. It is, in fact, very deleterious to blood flow, oxygen delivery to the microcapillary system and the capillaries themselves, the microcirculation and the capillaries, and that's where your oxygen nutrients exchange occurs and waste occurs. So when you disrupt that, you get global tissue hypoxemia. And there's consequences to that, and we see them. So arrhythmias and myocardial necrosis from massive uses of inotropes. How many times have we seen patients on 30 mics of Levophed, 20 mics of Neo, 10 mics of Epi? Let's throw some dobutamine on there as well. Let's add the vasopressin. And they have a blood pressure. That's all. They have a blood pressure. And we're going to talk about blood pressure and perfusion because they're not the same thing at all. And then, of course, you have to consider adverse effects of blood transfusions. We talked about that yesterday. I understand blood transfusions carry risks. I do. And I understand that and respect that. But I also think that not having sufficient oxygen content is another problem. Not to mention red blood cells are our primary buffer. So you're trying to deal with, that. They're also responsible for an enormous amount of our oncotic pressure to keep our fluid in the vascular space and not let it leak out, along with albumin. But usually we see anemia, we see hypoalbuminemia, total proteins are very low, and again, you're pouring fluid in, it lasts for a few minutes, and it's gone. Now I understand albumin doesn't last forever either, but it can be used very effectively along with CVVH and all that kind of stuff, which I'm a strong advocate of in dealing with critically ill, hemodynamically unstable patients that have fluid balance challenges, if you will. So yeah, there's adverse effects of blood transfusions. There's also adverse effects of not giving patients blood. But you have to have blood that's not 42 days old. Maybe 4, 5, 6 days. But that's another subject. We had talked about it yesterday. Supply and demand is a very small gap. It's very easy in a mass casualty, or like we just saw in a pandemic where you lose supply because you don't have donors, people going to give the blood because of all of this fright over corona. And then all of a sudden you don't have enough blood in the national blood reserves to take care of the patients or the private blood banks. But I mean national blood reserves in the sense of these private industries that have blood banks around the country, and there's 3 of them, 3 major ones. So endpoints based on cardiac output and other macrovascular parameters may not really be that important, and this is a very important concept to understand. Macrovascular flow does not mean microvascular flow. I told you can have a great blood pressure. It doesn't mean you have perfusion at all. Changes in sepsis, you can get microvascular thrombi and severe endothelial dysfunction. In fact, if you look at a lot of the videos that are done using the side stream dark field imaging, and you look at the microvascular bed, which is very conveniently located, visualized rather, under the tongue, and it's reflective of the gut, you can see actual rolling white blood cells. You can see perfusion deficits, whether it be hyperdynamic, normal, or essentially shut down with whole capillary beds disappearing. So microvascular imaging, for some reason we don't do it on a routine basis. I don't understand why. I think it's highly predictive. I think we should do it, but we don't. And it's not even that it's very expensive. It's not a big cost involved. So I don't understand our lack of imaging. You know, Dr. Lumsden down at Methodist DeBakey Heart and Vascular Institute, somebody who I really do adore the man, respect him tremendously. But he says it all the time: imaging. It's about imaging. Now he means that he's a vascular surgeon, so he means that at a certain level. He means CT, he means MRI, he means fluoro, he means that kind of imaging. But I sort of steal that from him and say it's about information. The more we have, the better we will be. And I think we need to start really exploring why it is we rely so much on antiquated, ancient technology and not embracing the latest and greatest, newest technology that the best minds in the world have developed. Makes no sense to me, but it's where we're at, all right? So you have impaired autoregulation. Microflow is linked to outcomes, so your microvascular blood flow is directly linked to outcomes. If it's deranged, you're not going to do well. If it's good, you're going to should do better. You have a better chance, higher survivability. The microvasculature can be manipulated, so you can affect it with dobutamine in an adverse way. And then some proscriptive targets may not be suitable for everyone. So a higher mean arterial pressure may be needed for an elderly patient, but somebody else may need a lower mean arterial pressure, and hematocrits for young, otherwise healthy patients and fit patients may not be suitable for older, sicker patients with higher comorbidities. And I think that's another thing, is these artificial thresholds that we use when we say we're going to keep the hematocrit, our transfusion trigger is X. Well, that's ridiculous. Your transfusion trigger for this type of patient should be X, and for that type of patient should be Y, and for that type of patient should be Z. That's how we're talking about this as goal-directed therapy. What's the goal? The goal is to deliver oxygen to the tissue. How do you have oxygen in your blood that is capable of getting to tissue? You need hemoglobin. That's blood. So, your hemoglobin is 6, your oxygen content, your oxygen carrying capacity is compromised. I put this on here, this slide here, or rather Victoria did put this slide on here just to show post-surgical complication rates. They're very common. It's not just cardiac surgery. This is really a critical care tool, but of course my bias is cardiac surgery. So that's sort of the direction that I go with this. We have plenty of cardiac patients who are eligible for hemodynamic optimization. It is not just for this type of surgery, but this type of surgery too needs it. Now look, this may be very basic for some, but we all understand Starling's law. The more preload, the more you fill the heart, the stronger it will contract up to a certain point, and then it starts to go down. You overfill the heart and you go into heart failure. But the further it's stretched, again, to a point, the top of the Starling curve, the stronger the contractility will be. But there's also this curve. I just want to go ahead and get to it. Yeah, there it is. The Bellamy curve. And what you see there in the green is your volume load and where the optimal range is. When you are hypovolemic, then you have hypoperfusion, organ dysfunction, and adverse outcomes. And you can see that as you become overloaded, you get edema, which results in organ dysfunction and again, adverse outcomes. Our goal is to be somewhere in that green. The question is, how do we get in that green? How do we know we're in that green, that we don't have too little volume in the circulation versus too much volume in the circulation? Now, there are ways to do that, and we're going to certainly talk about them. So these are some of the issues that can occur. I won't go over them, but I'm just going to skip over them. But effects of low volume fluid or hypovolemia and what that looks like. And then here's the effects of fluid overload. We've all seen this. You have pulmonary edema. You have the gut can't even put the intestines back into the belly, and all of this is from edema because the patient is fluid overloaded. That what you see there in the gut, that belly, those distended, swollen, edematous intestines is not from intravascular fluid overload. That's tissue edema. That's the patient that you see that looks like the Michelin Man. They're so swollen. And it results in a lot of things like coagulopathy, and it's just a cycle. It's just a huge problem. Lack of ability to oxygenate. You got to go on the vent. There's, you got to have high PEEP. Now you got barotrauma of the lungs. You got all these things to worry about. So hemodilution and coagulopathy, of course, is another big problem because you're causing this derangement. So we're talking about blood transfusions. Now you're putting the patient in a situation where they're going to start bleeding, and you end up giving more blood transfusions than you should have had to give, all because of mismanagement of fluid balance. So this is a very important curve here. And what you're looking at is a comparison of stroke volume variation, pulse pressure variation, CVP, and the PA pressure from the Swan. And if you look at the y-axis, that's on the left, right, going up and down, that is your sensitivity. If you look at the x-axis, which is specificity going from left to right on the bottom, okay, you can see that there is much, much higher sensitivity and specificity for volume status when you look at stroke volume variation and pulse pressure variation than with what is our typical way of doing it, CVP and pulmonary artery pressure. And this is very important to understand. We're going to talk about stroke volume variation and pulse pressure variation as we go forward here, but I needed to get this first concept to you, please. So a low CVP does not mean your patient needs fluid. Well, what? I mean, that doesn't make sense to a lot of people, but it really does make sense. If I take a normal, healthy individual with a normal blood pressure and I give them a big whopping dose of nitroglycerin intravenously, their CVP is going to plummet because I'm increasing the size of the tank. The tank is set up, being the vascular system, to accommodate this much volume for the heart to be this full, to be pumped around to all back and forth to the tissues. If I increase the capacity of it by dilating the patient, then we are creating hypovolemia. So a low CVP does not necessarily mean the patient needs fluid. Now, that patient, if we keep them dilated like that, may very well need fluid to get the tank filled back up again, so you have a preload for the heart to be able to pump, and then you could treat the afterload with something else if it doesn't generate a high enough blood pressure because they're so vasodilated. But it'd be a lot easier to just not keep giving them the nitroglycerin and let them tighten back up again to a normal vascular resistance or vascular tone. And I see this on cardiopulmonary bypass, in fact. If I'm flowing 4 liters a minute and I have a blood pressure of, let's say, 40, we just went on, or I just gave cardioplegia, or I put some mannitol in, or whatever the cause was that caused that blood pressure to go down to about 40. My SVR dropped, and I have a level in my oxygenator of 700 cc's, 800 cc's, whatever it might be. When I bump them with some Neo and that blood pressure comes up, if I keep the flow the same, I can see the level in the oxygenator rise. So I know, I've validated that this is actually what does occur. Okay? Do we have a caller? Or was it? No? Oh, okay. I'm sorry. I thought we had a caller. Forgive me. So there are no data, and this is important, that supports the widespread practice of using CVP to guide fluid therapy. We've just always done it. But it really should be, according to this article that was written by Dr. Marek, should be abandoned. And that's a strong statement. Oh, where'd I go? Oh, is that the slide I was on, or was I on this slide? What happened? Oh, there's the conclusion. Sorry. Oh, I got confused. I'm sorry. Sorry, guys. Okay. So blood pressure alone, arterial blood pressure, is it useful or is it misleading? Now look, this is really something. Alfred Blalock of the Blalock tossing procedure in 1943 said, "It is well known by those interested in this subject that the blood volume and cardiac output are usually diminished in traumatic shock before the arterial blood pressure declines significantly." So when you measure only blood pressure, the blood pressure can be artificially raised by the body in response to hypovolemic shock, because it's going to just keep constricting and constricting and constricting to give itself a blood pressure, thereby reducing the size of the tank, as I talked about earlier. So the opposite effect of the nitroglycerin. Now you're squeezing it, right? So there are several assumptions, okay? Blood pressure reflects flow. Mean arterial pressure equals cardiac output. If the BP goes up, then the cardiac output goes up. If the cardiac output is down, then the blood pressure is down. So the assumption here is that pressure equals flow, and clearly it's wrong. I know a lot of you that are, more advanced get that, but there's a lot of people who really don't, and it's very important. Pressure does not equal flow. Just because you got a good blood pressure doesn't mean you are perfusing the tissue functionally at all or well at all. Let's see here. So in this particular scenario here, what you see, the bottom line here is they studied 402 patients in 4 centers. Response to volume expansion was defined as more than a 15% increase in cardiac output. So they gave volume challenges, and the goal was a 15% increase in cardiac output. The volume expansion induced changes in systolic, diastolic amines and pulse pressure ranged from between 0.64 and 0.70 with a sensitivity only of 52 to 79%, which is extremely low. So I really don't understand this slide. I think basically from anesthesiology, I think what they're basically saying is that arterial blood pressure is not a good tool to use to detect cardiac output and then decide to use volume expansion for correction of a low cardiac output. That's what I believe they are trying to say here. I'm really not sure. I probably should have just skipped that slide. And the answer is no. I didn't even see that. The answer is no. It's not a good tool. That's what I said. Blood pressure equals cardiac output times SVR. Cardiac output is defined by stroke volume times the heart rate. Decreases in stroke volume cause an increase in heart rate. Decreases in cardiac output cause an increase in SVR. We talked about that, right? If you're bleeding out and your cardiac output's falling, your body is going to attempt to keep a blood pressure. It's going to constrict, okay? Compensatory changes keep the blood pressure close to normal initially in shock states. Blood pressure does not change until late due to these compensatory responses. Blood pressure, while important, because we need it for a perfusion pressure, you need to have a cerebral perfusion pressure, you have to have your kidneys being perfused, you have to have a blood pressure. Blood pressure is an important parameter to monitor. It's just not on its own gonna tell you enough, but it will tell you quite a bit about your perfusion pressure. Okay, that's pretty much all. Normal blood pressure, you can have a normal blood pressure in all 3 of these conditions. Again, a normal blood pressure. High SVR, low cardiac output, as in hemorrhagic shock, or on ECMO, or cardiogenic shock for that matter. You can have a normal blood pressure with a low SVR, but a super hyperdynamic heart and a high cardiac output. I've seen that many times, such as we see in sepsis. We have seen it. And that's a big problem. In fact, if we go backwards, I've talked in this studio about never put a patient who has pure pulmonary failure with a hyperdynamic or even normal cardiac function on VA ECMO with femoral cannulation. Don't ever do that, because if you do, you are going to have differential hypoxemia and the patient is not going to do well. They're going to have an anoxic brain injury before too long. Don't ever do that. You never use VA ECMO with peripheral cannulation when you have a patient who has a normal or hyperdynamic cardiac output or heart with pure pulmonary failure. You can do VVA if you really want to. You can do VVV, but you cannot do VA with peripheral cannulation. You can do it with central cannulation if you want to, but that's about it. And I don't even suggest that. You can have a normal blood pressure with a normal SVR and a normal cardiac output, as you would find in a healthy person. So I want to talk about the compensatory mechanisms. And this device that you see here on the bottom left, the top is just a hemodynamic monitor. That's the Edwards EV1000, just so you know. And I think I disclosed this. I have no disclosures. I do not work for Edwards. They've never done anything for us. They're not one of our advertisers. Nothing. Wish they would be, though, because they could, you know. But nevertheless, because I think, they have another device. I could talk about it. It's the LIDCO device. But you know what? They were kind enough to share these slides with that on it, so I'm going to stay with them. So some compensatory mechanism is when the stroke volume falls, the heart rate will compensate to keep the cardiac output normal. When the cardiac output falls, the heart rate again compensates. But it will fail eventually. Vasoconstriction and increased systemic vascular resistance and it will change, but the blood pressure will remain the same. Increased oxygen extraction occurs, and this is where having a central venous oxygen saturation is very important. But initially, you'll see a peripheral change, but centrally, it's actually delayed, and that's very important. So you may not actually see that you have higher extraction with the central venous line, but you'll see it eventually. It's going to happen. So those are important things to understand, that stroke volume falls, cardiac output will compensate to keep up. Cardiac output falls, the heart rate compensation will fail eventually. Those are the important concepts there. Mean arterial pressure and volume loss. Okay, well, we're all very familiar. We just talked about this. You can see again on the y-axis over there, normal. You can see the blood volume lost on the x-axis, and by the time you get to about 18%, maybe 20%, you start seeing the mean arterial pressure start to drop off. And the cardiac output. So if you take into consideration that I have a circulating blood volume of probably 6 liters, when I've lost, I'd have to lose 1,200 cc's, 1.2 liters of blood volume before you saw an appreciable drop, something that would make you be concerned in my blood pressure. But look at what happens to the SVR. It really cranks up there very quickly, and that's an important thing to understand too. Cardiac output, mean arterial pressure, the cardiac output's falling, the mean arterial pressure staying the same, but the SVR is climbing to compensate for it again, making the compartment smaller, if you'll making the tank smaller. That's very important again. Hemodynamic parameters, cardiac output, cardiac index. These are just, the abbreviations. SV is stroke volume index, and stroke volume variation, SVV. We're going to talk about what stroke volume variation is. So here is your cardiac output, which is controlled by stroke volume and heart rate. Your stroke volume is controlled by preload, afterload, and contractility. Your cardiac output and your cardiac index are thus, I don't really need to spend much time on this, but they're just indices that we typically measure. Stroke volume, the amount of blood the ventricle pumps, okay, what the normal range is in your stroke volume index and how that's calculated. Again, I don't want to spend too much time on this. Let's see, where are we at? Stroke volume variation. Now we're getting somewhere. Stroke volume variation is the difference in stroke volume or arterial pressure observed throughout a respiratory cycle while a patient is mechanically ventilated. So we've all seen it, right? Back in the old days, the ventilator would be going off and you would see the blood pressure going like this. And we would say that patient's empty, that they need volume. We would see the systolic pressure and it'd go down with inspiration and then back up and then back down. And we knew immediately the patient was hypovolemic and we would give them volume, okay? And the cause of that, we're all familiar with that. We know why that happens. So this device, this EV1000, measures stroke volume on a beat-to-beat basis, very important, and stroke volume index, but stroke volume variation, and this is where it gets very important. You want it to be less than 13. Now, I'm not 100% sure what I know that number 13 means. It needs to be less than 13. I probably should have asked that question. So what it tells you is should you or should you not give this patient volume? And if you look over at the inset, the Starling curve, you can see that if the delta stroke volume, or the systolic, I'm sorry, the stroke volume, is it stroke volume or systolic pressure variation? Systolic, well, okay. So if the stroke volume variation is greater than 10%, you need to give fluids. If the stroke volume is less than 10%, then you need to discontinue fluids. So if you take your patient and you're measuring the systolic pressure variation or stroke volume variation, whichever you want to call it, and that's your preload, and you're on mechanical ventilation, that's an important thing you have to acknowledge here, okay? This isn't for patients who are just breathing on their own, on mechanically ventilated. And your stroke volume variation is changing greater than 13, whatever that number means, by this monitor, then that patient needs fluid. But when it's no longer changing by that much, then your preload is perfect. Any additional fluid will not result in any improvement in cardiac output. In fact, it will probably result in you losing cardiac output because you're going to go over the top of the Starling curve and overfill that heart. So it's very helpful to look at stroke volume variation electronically, because by the eye, when it's profound, you can see it. It's easy. But when it gets narrower and narrower, when you want to optimize, fine tune, you really want to use that stroke volume variation program that exists within this monitor. So here we are with stroke volume variation. The magic number is 13. The higher the stroke volume variation, the higher. So 13, 15, 18, 20, 22, 25, the higher, the drier the patient. And here it tells you, if it is in fact greater than 13%, then, and the answer is yes, if on the left side, you give volume challenges. You give, if it's no, then you do inotropes, pressors, or even diuretics, because you may just be too full. And diuresing the patient, which would be like that patient I told you about in the operating room, heart was stuffed, it was edematous. We started ultrafiltrating the fluid off. We gave them albumin, we raised their COP up, we gave them blood. We just kept pulling plasma water off of that patient. I think I took out like 3,000 cc's within the course of maybe an hour and a half, very short amount of time. And that patient looked so much better. It was just massive fluid overload. So if you have a very high stroke volume variation, you need volume. If you have a low stroke volume variation or none at all, you need pressors, inotropes, diuretics, or possibly all three. With ARDS, you know, of course, you're on mechanical ventilation, and it's very useful to use this here for fluid resuscitation and to make sure you are euvolemic. You don't want a patient who is ARDS to be fluid overloaded. It's a huge problem, because we really need to get the ventilator, mechanical ventilation, decreased to lower the barotrauma, the high oxygen infusion or high FiO2s on the vent, and the problems that occurs with the corrosive nature of that for the alveoli we're trying to protect. So maximizing, optimizing your preload for your heart to give yourself the best cardiac output O2 delivery is very, very important. Now, there are some limitations to stroke volume variation. Currently, literature supports the use of SVV on patients that are 100% mechanically ventilated with tidal volumes of equal to or greater than 8 cc's per kilogram and fixed respiratory rates. So I'm not a pulmonologist, and I know they do some fancy stuff with ventilators, but it does have to be a fixed respiratory rate. If they're spontaneously breathing, it can create problems. If they have arrhythmias, it can cause problems. So it's kind of like timing the balloon pump when they're in AFib. You know, nothing is perfect, but it certainly does work for most patients. And you can usually treat those problems and get them corrected, and then it works very, very well. So here is preload stroke volume variation in relationship to stroke volume. You can see that as stroke volume decreases, stroke volume variation increases. Volume responsiveness, and what does that look like? So in the top, the stroke volume variation is less than 13%, so we would call that fluid optimized. It's not perfect, you can see that there's some change, but it's less than 13%, so the 13 must be a percent. Stroke volume variation of greater than 13%, and you can see there as they draw the line how different that is. It's very fluid dependent, and we've all seen this. But making it optimized is very important. And you can see that right there with the Starling curve, you're right at the top of it with that stroke volume variation of less than 13%. Oh, did I do this slide? Oh, I'm sorry. Well, okay, so I was talking about, I went ahead of myself. So here, there's the stroke volume variation. As stroke volume goes down, decreases, stroke volume variation increases. I talked about that. There you go, some fancy graphics. And this was the slide. I was on it on my computer because I have to look at it to see. But here is volume responsiveness. What does it look like? So you see on the top how nice and even those systolic peaks are. There's some, but very little variation. That's the top of your Starling curve. That's fluid optimization for preload. And you look down at the bottom, you can see that curve and how wavy it is. And that is classic for hypovolemia. But now you actually have a number, because if you just look at that, you may recognize it, may not, as it becomes less subtle, as it becomes less, but still more than 13%, you may not be able to distinguish that, because even if you look up at the top, you can see there is some variation. But, you know, would you call that more or less than 13%? I don't know. I think that it's better to have an actual number that you can measure. So take-home message is stroke volume on, you can measure stroke volume on any patient, anytime, anywhere. Stroke volume variation is an adjunct to predict volume responsiveness. Use both together on appropriate patients. And the rest of this is really just, I'll just kind of skip through the slides very quickly. There's an example of high afterload. So you basically, on the right-hand side, look at that. You can see P1 and P3 are the tanks they're trying to pump. They're like pistons, and you're trying to push it through P2 or P4. Well, you know, you can tell me yourself what you think the pressures are going to be, right? So the SVR, the systemic vascular resistance, equals the mean arterial pressure minus the CVP divided by the cardiac output. P3 to P4 is going to fly through that with a low pressure because it has very low resistance. P1 to P2 is going to have a tough time. There's going to be a struggle there, because as you increase that afterload on the heart, you increase the workload the heart has to do. And if you've already got a perfusion deficit, or you have an oxygen deficit to the myocardium, imagine making it work really hard to get something through that hole. So really getting your SVR optimized, getting your fluid balance optimized, getting your hemoglobin optimized, getting your colloid oncotic pressure optimized with albumin, getting your coagulation optimized as best you can, getting and fluid balance is really, I think CVVH is the only way to do it. I don't think you should whip the kidneys with diuretics. You know, even on a patient that supposedly has normal kidneys, I see no point in it. I think when you whip these kidneys like that on challenged patients that have perfusion oxygen deficits, knowing how low the PO2 is in the glomerulus, it's low, it's around 20. There's not a lot of room there for error. And I believe in CVVH and think it should be used. So optimizing all of these things using this tool, this EV1000, which I highly recommend everybody go look at. I think it's I've seen it in action. I've actually used it on patient. I didn't use it, but Victoria was there and I watched the procedure and saw the parameters. It's a very, very good device, very useful. You know, I think there's a lot of value in it. We talked about, oh, here, no, I forgot. She's got all these fancy graphics. I'm just used to pushing the button to go into the next slide. We all know what contractility is. You know, we talked about that. The more volume in the heart, the stronger the contraction is going to be. That's because it's a striated muscle, the heart muscle. But the heart muscle, because it is striated, if you overstuff it, you can actually break it and it won't come back and work. You tear those bonds. Really problematic. So, you know, surgeons get real nervous when they see a heart blowing up, because they know if you blow it up enough, it's not going to beat properly ever again. That's a big, huge concern and problem. So there's no point in doing that. But once you stuff it so much, it just starts to fail. So more volume increases contractility, increases cardiac output to a point, and then it levels off and then starts to go down and you go into heart failure. These are just, you know, some descriptions of what things are, and there's a whole big long reference list that you can look at. We can open the phone lines. Let me put that up there so people can get a good look at it. And here, make sure that's up on there, that slide, so that they can stop search. You know, they can take a screenshot of it or what they want to do if they want to read that stuff. Oh, thanks. Perfect. Okay, good. And we can, you know what I'm going to do? I'm going to tell everybody at this point, thanks, David. I'm going to tell everybody at this point that I'm going to see y'all tomorrow. I think we have a good show coming up tomorrow. Hey, Dave, you could take that slide down. Thanks. Perfect. Thank you. There y'all are again. I saw that there's a lot of references, so I'm glad you left it up as long as you did, because people need to get a good shot of that. But I want to thank Victoria Crumpton again. She was very gracious, very generous. I appreciate you. I highly recommend you. Oh, we have a caller. I highly recommend you check out the EV1000. And if you happen to be watching this from Edwards, if you would be so kind, is maybe you would like to advertise on our show. But that's up to y'all. We're always interested in talking to people. We have a caller, actually. No. It was a bad. Are you? Oh, they're calling back. Yeah. Hi. Hi, you're on the air. Who's this?
This is Mr. Al-Harbi. I'm calling from Saudi Arabia. Thank you very much about your topic.
Say again, sir?
This is Mr. Al-Harbi. I'm calling from Saudi Arabia.
Thank you. What's your question, sir?
My question about hyperdynamic situation for pheno ECMO patient. Could we measure the cardiac output routinely for pheno patient daily to help us to calculate our ECMO cardiac output ratio?
I think so. I do think so. I think as long as you're ventilating at 8 milliliters per kilogram, and I think that's going to be important. And as long as you have a set rate, then and you have a good access for your blood pressure, this device will measure your cardiac output. Now, where it will get a little, because you're only doing VV ECMO, you're not in the arterial system. Now, it may be an issue where if you're measuring, of course, central venous saturation, or you're measuring CVP, which really has limited value, but if you are, of course, on VV ECMO, that's going to be very useless. I mean, that number's not going to really help you a lot. but it is going to tell you what your stroke volume variation is, because that is going to be based on your arterial waveform and your stroke volume variation, or your systolic pressure variation, if you will. Pulse pressure variation, systolic pressure variation, those parameters are going to stay intact even though you are on VV ECMO. So I think then this device would be very useful in that setting, yes.
Thank you. Just my second question. If I don't have any things that help me to measure the patient cardiac output, how could I know that my patient already have hyperdynamic situation now, and I should start to give him beta blocker or something to reduce his cardiac output to maintain the flow ratio between the ECMO and cardiac output?
That's a very, very good question. Again, if you are on veno, it depends. If you're on, even on veno-venous ECMO.
Veno.
Yeah, if you're on veno-veno ECMO and you have a hyperdynamic cardiac output, let's say you can only get 5 liters through your ECMO, but the patient's cardiac output is 10 liters, and you have 0 or limited lung capacity, then what you need to do in that circumstance is you need to add an extra line. I have done VV ECMO with 2 accesses and 1 return. I have also done the 1 access and 2 returns with success. But I have a friend of mine who has actually done 2 independent ECMO circuits on 1 patient, VV, to have enough flow to accommodate the patient's cardiac output, so they did not have still a diminished oxygen saturation going to their head. And that's what it took. Their cardiac output was about 15 liters, and they had to use 2 separate VV ECMO circuits in that patient. Now, the caveat to that is you have to be very careful where you put the tubes, because you can get a lot of recirculation, and even though you have a lot of flow, it may not necessarily be effective flow. So you really have to think through your cannulation.
Thank you very much.
You're welcome, sir. Take care, and thank you. That was excellent questions. We appreciate you.
Thank you.
Mm-hmm. Okay, with that said, I think that was one of the best questions we have gotten on this program, all the way from Saudi Arabia, and we appreciate you so very much. And you can also email me, okay, Doc? So here's my email right there, contact@perfusioneducation.com. You can send me an email, and I can also get some additional resources to you, both about the EV1000 and managing patients that may be on ECMO with the stroke volume variation. And I can also send you some real good information on how to manage patients with very high cardiac outputs and super hyperdynamic and pulmonary failure, the need for ECMO. So if you'll send me an email to that address, we will get that to you ASAP. Everyone have a good evening. Thank you for your time and attention. We will see you tomorrow, same time, same station.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova Wrap Cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of wrap improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking? hotel, and meals out, this totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.